Hello, I'm Rahul Gosain, one of the community medical oncologists, alongside my brother Rahul Gosain, community medical oncologist as well, and we are the Oncology Brothers. Welcome to this clinical insights segment. Upper GI space is changing too fast. What we've seen from 2025 in earlier stages is data from Matterhorn, which led to the approval of durvalumab. Here at GI-ASCO 2026, what we are seeing is Horizon GEA-01, which is bringing in Zanidatamab, combining that with chemotherapy plus minus tislelizumab. To walk us through the data at hand and more, we have a great panel, starting out with Dr. Nataliya Uboha from University of Wisconsin, Dr. Jeffrey Koo from MSK, and Dr. Rutika Mehta and Dr. Manish from Weill Cornell. Welcome, everyone.
Thank you.
Thank you.
Thank you.
Great to be with you.
Welcome. Rutika, before we dive into the data for Horizon GEA-01, can you set the stage of what is the current standard of care for that HER2 metastatic GE junction or gastric adenocarcinoma today in frontline settings?
Yeah, absolutely. So when a patient walks into the door with stage 4 or advanced unresectable metastatic GE cancer, we're typically looking at 4 different biomarkers: MMR, HER2, PD-L1, and Claudin 18.2. If the patient is MMR proficient but HER2 positive, I'm also looking at their PD-L1 status to know whether I should be combining chemotherapy trastuzumab with pembro for PD-L1 positive patients. But if they're negative, then we have chemotherapy plus trastuzumab. So that's our current standard of practice. So HER2 positive, PD-L1 negative is chemo plus trastuzumab, and HER2 positive, PD-L1 positive is chemotherapy, trastuzumab plus pembrolizumab.
What's the prevalence of HER2 positive disease for GE junction and gastric adenocarcinoma?
I would say about 15 to 20%, some slightly higher depending on how you count esophageal versus gastric separately.
Thanks for laying that foundation, Rutika. Manish, what we know from Horizon GEA-01 is Zanidatamab with impressive results, which we will dive into the data soon enough. However, what we know from this is this was approved in biliary tract cancer in November 2024.
Right.
Could you go over the mechanism of action for Zanidatamab, please?
Right. So it's a new class of drugs called a bispecific. So there are two parts of an antibody. One part is binding to one part of HER2, and the other part is binding to another part. It's there are four external motifs. Motif 2 and motif 4 are the binding sites. It's similar to the binding sites of trastuzumab and pertuzumab, and the unique thing about this is that by the dual binding, you're able to get clustering of more HER2 molecules and more immune activation. That's at least the thinking.
Keeping that in mind, we know that pertuzumab was tested in this space and that data was negative. Jeff, here at GI-ASCO 2026, Horizon GEA-01 has to be one of the biggest stories coming out. Can you touch on the study design and its findings?
Yeah, I mean, I actually would make the point that, the pertuzumab study was a near miss. So I think even then, there was always a rationale to continue to evaluate, trastuzumab and pertuzumab-like strategies. And again, like Manish said, the thought is that having both of these molecules on the same antibody really gives you a very specific and differentiated mechanism of action. So sort of the basis for Horizon GEA-01 is that it was a phase 3 study in the first line setting, and there are 3 arms. And actually maybe, going through arm A to C will be helpful since we'll be referring to them repeatedly. So arm A was a control arm of trastuzumab and chemotherapy. Arm B was Zanidatamab with chemotherapy, and arm C was Zanidatamab with tislelizumab, an anti-PD-1 antibody, and chemotherapy. Now, everyone will notice that arm A excludes pembrolizumab, which is the current standard of care. And at the time that the study was launched, it had already been approved in the US. So the combination of pembrolizumab, trastuzumab, and chemotherapy, but was not approved anywhere else in the world. And for that reason, this was actually an ex-US study. There were patients from North America, from Canada, where you both hail from, but there were no patients from the US.
Absolutely. So keeping all that in mind, what are we learning from? What did the data show?
Yeah, so the data, showed, I think, a couple of things very clearly. That Zanidatamab plus chemotherapy is superior to trastuzumab plus chemotherapy in terms of progression-free survival. And at this point, there is also a clinically meaningful, but near statistical significance in terms of improvement in overall survival. Now, one thing to keep in mind is that the overall survival analyses, this is actually the first of several planned analyses. The p-value, is I think a little bit more than 0.05. And certainly the hope and expectation is that with additional follow-up, we will see that the comparison of arm B to C will be statistically significant as well. Now, the other very notable finding is that the other experimental arm C, so Zani, Tislelizumab, and chemo, was statistically significantly superior and clinically, there's quite a big clinical benefit in terms of improving PFS as well as overall survival relative to the control arm of trastuzumab and chemotherapy.
Thanks for that data, Jeff. With regards to, these are impressive results, but this is also despite the PD-L1 score, which when compared to chemotherapy, trastuzumab, and tying in with the pembrolizumab, that is only for PD-L1 positive case.